I'm a transplant nephrologist. I'm not a surgeon. I don't do any of the surgery myself. My role is to help those of us here today who are either approaching kidney failure or on dialysis already, to try and help you make up your mind what's the best way forward in terms of treatment options for you. Is dialysis perhaps safer, or could kidney transplantation offer you as an individual a better option in terms of quality of life and survival? And so as we go through the evening, I'm going to talk a little bit about what normal kidney function entails, what are some of the treatment options we have today available for those of us that are actually suffering from kidney failure. Why would you want to consider kidney transplant? We'll look at some of the statistics associated with dialysis and transplant. We will talk about living kidney donation. We'll touch upon what we call paired donation or kidney swaps if you have an incompatible donor. And then I'll try and explain a new category of wait list that is called, and it's not so new anymore, but it's called a KDPI greater than 85%. We'll talk about that a little bit. Time permitting, we'll also touch upon what the future might hold. Now, almost all of us are born with two kidneys. Some of us, less than 1% of the population, are born with a single kidney. Those of us that are born with a single kidney typically live our entire lives out with the one kidney, and perhaps may never know unless you find out accidentally because you had a CAT scan or an ultrasound for some other reason. But this is kind of looking at a cartoon cutout from the back. You've got the spinal column taken out over there, and the two kidneys sit very high up in the back, right under the diaphragm. And if you think about kidney function in its very simplest form, think of the kidneys as a sieve. Every cell in our body, minute to second, generates toxins. Food and drink that we consume accumulates in the body and has to be eliminated as well. The blood from the heart gets pumped to the kidney. When those blood vessels enter the kidney, they divide and subdivide into essentially almost 1 million little filtering units called the glomerulus. Each kidney, these are so small that each kidney has about 1 million of these filtering units. And effectively what happens then is it filters the blood, and you have urine formed and coming out through a tube that we call the ureter that goes down to the bladder. We eliminate that as urine, and of course the clean blood then goes back into the body, and this goes on continuously around the clock. Each kidney is just about the size of a fist. Each kidney weighs only about 1/4 pound, and so the two kidneys together make up only about 1/2 pound of your body weight. But to give you a sense of how much work they perform, at any given moment, a full quarter of all of the blood that is being pumped from the heart is going through the kidneys. They are very integral in regulating blood pressure. If you did not have problems with high blood pressure before you develop kidney problems, most of us, by the time our kidney function drops below 30% or 20%, will start developing high blood pressure just as a consequence of the kidney failure. The kidneys manufacture vitamin D, which is important for calcium levels and regulating bone strength. Erythropoietin is a hormone made in the kidney. Some of us may know that as EPO or Procrit or Aranesp injections that you either get on dialysis or give yourself at home. This is a hormone that is produced in the kidney and travels to the bone marrow. It stimulates the bone marrow to produce red blood cells or hemoglobin. That's the component in the blood that actually carries the oxygen from our lungs to the rest of our body. Renin is another hormone that is produced in the kidney. It's responsible for regulating both blood pressure as well as chemicals like potassium. In addition to cleaning the blood, the kidneys maintain levels of acid and minerals in the blood within a very, very tight range. Too low or too high, and you can very quickly get sick and perhaps even die. But as I said, at its very integral form, think about kidney function as a sieve filtering all of the waste products. What then is end-stage kidney disease? It is the irreversible loss of kidney function that requires either dialysis or a kidney transplant simply to sustain life. Now, for most of us, as we lose kidney function over time, if we're losing it very, very slowly over many years, we may actually not start feeling ill from it until the kidney function drops really low. In fact, oftentimes the earliest symptom that you may have is when your kidney function is already down to maybe 20% or a little bit lower, and that's when you start noticing that you're slowing down a bit, maybe a little fatigued. But for most of us, by the time our kidney function gets to about the 10–11% range, that's when we start feeling ill. At that point, we may start developing weight loss, we lose our appetite, our sense of taste changes, we may have a metallic taste in our mouth. A lot of people will develop itching that they cannot explain. Nausea may develop also. And if at this point you don't actually start dialysis or undergo a kidney transplant, as your kidney function declines further, by the time it gets down to the 4–5%, most of us will be confused, and very, very shortly thereafter we would slip into a coma and pass away. If you look at the scope of kidney disease, it's the incidence of kidney failure in the country has been increasing steadily over the years, and I'm going to come back to this in a second. But if you look at figures from 2010, nearly a decade ago, there were close to 1 million fellow citizens in the United States suffering from total kidney failure. The cost every year to the country for treating this condition is well over now $50 billion a year. And it turns out, at least in the United States, diabetes, sugar diabetes, and high blood pressure, between them, account for about 2/3 of all cases of kidney failure here in the US. Where do we stand in our ability to treat this condition? This is a can called Kidney Wart that was produced in the early 1900s. I actually bought it in a sidewalk sale during one of my vacations. You can't quite read the label on that, but it says that it was the safest, easiest, best ever discovered treatment for all kinds of kidney problems. Needless to say, no better than snake oil. But we've come a long way. Today, for those of us that have kidney failure, the mainstay of treatment is dialysis. It's either hemodialysis, blood dialysis. You can see the gentleman sitting over here. He actually has what we call a shunt that's been surgically placed in the arm that diverts blood from the artery to the vein. And that shunt then can be used to place little needles into it. Blood then is taken through the needles and circulated by the help of a pump in this machine. And the machine itself has a filter which filters the blood in place of the kidneys filtering the blood. For most people who do hemodialysis, blood dialysis, the majority of them come into a center 3 days a week and are on the machine somewhere between 3.5 to 4 hours. Some people are able to do the blood dialysis at home as well. It does offer certain advantages over coming into a center, but from a practical perspective, it's not easy for everyone to perform. The other form of dialysis is what we call peritoneal dialysis, and it is in fact easy enough that a child can be taught how to do it. And basically the principle behind that is the inner lining of our belly is a very, very fine membrane called the peritoneum. That forms a cavity that is typically empty, and that lining has a very extensive lacy network of capillaries, of blood vessels. We surgically implant a catheter, and to do the dialysis, you put in clean fluid into the belly, and that lining of the belly then serves as the filter. The toxins come out into the fluid, you empty the dirty fluid, put clean fluid back in, and you kind of do that over and over again. For most of us, when we develop kidney failure, we start dialysis of one type or another. We then go on to get a kidney transplant, either from a living donor or a deceased donor. Should the transplant fail, you would go back onto dialysis. And at that point, if your health is adequate for you to allow you to safely go through a second or a third kidney transplant, there's no reason why you might not be able to do that. The world record is actually a gentleman in Spain who went through 8 kidney transplants through his lifetime, started very young. But if you look back at the history of kidney transplantation, this is a depiction of the first, although unsuccessful, attempt at a human kidney transplant. This was a surgeon in Ukraine all the way back in 1933. He'd already experimented a little bit, taking kidneys out of dogs and reimplanting the kidneys. He had learned the technique of stitching up the blood vessels again after taking the kidney out. As chance would have it, he had a young lady in his clinic that was dying from kidney failure due to mercury poisoning. A young man was struck in the hoof of his head by a horse right in front of the clinic, and the family rushed him in. The gentleman succumbed to that head injury, and with the permission of the family, the surgeon then took the kidney out. And as you can see here in this rather unusual looking picture, actually put it into the thigh of the woman. By the description, the kidney actually took and worked for a few hours and started producing urine. But very shortly thereafter, it very quickly became extremely swollen, became dark blue, and abruptly stopped working. The surgeon thought it was a technical failure, that the blood vessel anastomosis, the stitching of the blood vessels did not take, and the blood supply had been disrupted. We actually look back at this today and we recognize that what it probably was is a condition called hyperacute rejection, where the body already had either antibodies against the blood type of the kidney, or perhaps just preformed antibodies for other reasons, and the young lady developed very, very severe early rejection and lost the kidney. Now, back in those days, we didn't have a good sense about the process of rejection and what it entailed. For those of us that were sitting here looking at the screen, the painting that you saw is actually based on the very first successful solid kidney transplant performed all the way back at Christmas Eve 1954. By this time, we had a better sense of the process of rejection. We didn't fully understand it, but we knew some of the factors that produced it. However, in the 1950s, we still did not have the tools, we didn't have the medications to prevent rejection. And the only reason this operation was successful all those many years is because it took place between identical twin brothers. And if you have an identical twin, every tissue in your body is an exact match to your twins. And so you can take tissue or you can take an organ from one identical twin and put it in the other, and there would never be a process of rejection because the body then recognizes it as your own, and so you don't need rejection medication. And so these are the twin brothers sitting over here. And for those of us wondering who was the kidney donor, is the young man here with a scowl on his face. Remember, no one had ever donated a kidney before that. He was, in fact, walking down a path never before trodden. But the photograph on the other side is the two brothers smiling after the surgery, after having recovered. Richard Herrick was the twin who actually received the kidney. He went on to marry the nurse who took care of him in the post-operative period. They had a family. He lived for another 7 or 8 years, but the original kidney disease that destroyed his old kidneys came back in the new kidney. And at that time, we didn't have the ability to keep him alive with dialysis, and he succumbed to the kidney failure at that point. Ronald, the twin brother who actually donated the kidney, went on to live to the ripe old age of 79, died in December 2010. Now, since the 1950s, the actual surgical procedure has pretty much been perfected. People are often surprised that we don't take the old kidneys out. Remember, they sit high up in the back. The approach to get to those kidneys typically involves a very large incision that's technically more challenging and more painful. The new kidney instead goes down into the pelvis, either on the right side or the left side. You have blood vessels over there that go down from the pelvis down into your leg. So those blood vessels are accessible to the surgeons to stitch up the kidney to. Of course, the bladder sits right next to it over there, so the ureter, the tube that leads the urine from the kidney to the bladder, can also be easily stitched up over there. The incision is typically about 10 or 12 inches long. The operation takes anywhere between 3.5 to 4 hours. For most of our patients, after they get the kidney transplant, depending on how quickly it opens up and how quickly they recover, you might expect to be in hospital anywhere between 3 to 5 days. This is just another depiction of how that kidney kind of sits there in the pelvis. Of course, in real life, it doesn't look quite that neat. In real life, it doesn't come with all of these labels that tells me what to hook up to what. That's one of the reasons I don't do surgery. The other reason is blood makes me faint, so you don't want me in there. Anyhow, the first successful kidney transplant, actually the first successful solid organ transplant in the world that I showed you, was in 1954. 1988, the federal government started funding all dialysis and kidney transplantation, really all transplantation in the United States. So, sorry, not all transplantation, let me correct myself, all kidney transplantation. And since that time, as of the end of December of 2018, in the United States alone, we have performed almost 500,000 kidney transplants. And year by year, As in last year, you can see we did nearly over 21,000 kidney transplants. And year by year, about 2/3 of all solid organ transplants in this country are kidney transplants. That's where we have the most experience. But for those of us here today that actually have kidney failure, are perhaps already on dialysis, why might you want to consider kidney transplant? How many of us are on hemodialysis? We have quite a few. How many of us are on peritoneal dialysis? So quite a few on peritoneal dialysis as well, perhaps not quite as many as on hemodialysis, and that's a fair representation, I think, in general. But those of us who are here on dialysis instantly recognize what I mean by freedom from dialysis. If you're on hemodialysis, you have to come in 3 days a week. But by the time you get ready, you come in, you wait, you get on the machine, come off it, you wait, and then you get back home. And then oftentimes you take an hour or two to actually feel better from that process of dialysis. Half a day, if not the whole day, is pretty much gone. If you want to travel, you have to make arrangements well ahead of time. You can't just pack your bags and go on the spur of the moment. Especially if you're on hemodialysis, certainly less so on peritoneal dialysis perhaps. You have to be extremely careful with how much you're drinking and what you're eating, because everything that we consume stays in our body, and if our kidneys are not working, then that interval of 48 to 72 hours between each dialysis session is a danger period. And so you really have to be careful what you're consuming, because it accumulates until you get to your next dialysis session, which is when it's all cleaned away and taken out. Then there's the question of more normal kidney function. A lot of physicians, in fact, don't recognize that dialysis at best maybe replaces 9, 10, 11% of your kidney function, not very much more than that. It's enough to sustain your life, it's enough to sustain your health, but it's not enough to restore your health back to the way it ought to have been. If you have one kidney transplant that's working well, that's at 50%. In of itself, that's more than adequate to sustain your health and restore it. There is also the hope that with the new kidney now, it will be producing the vitamins and hormones that it should. But more importantly, there is the greater likelihood of a better functional status, a return to the strength and stamina that you used to have before you developed kidney failure. But perhaps most important, there may be the opportunity with a transplant to have a greater survival compared to dialysis. Now, we've known for a very long time that people who got a kidney transplant lived longer than their counterparts who were on dialysis. The problem with that was transplant has always been a very high-risk procedure. We've always had to very carefully select individuals to go through transplantation so that they're able to survive the transplant event and then actually see the benefit from the kidney transplant. So if then you say, well, people who get a transplant are living longer than people on dialysis, what does that really mean? Because if you're selecting out healthier individuals, you would expect them to live longer. And it really wasn't until the seminal study that was published all the way back now in 1999 that we realized for the first time what a big difference kidney transplant may actually make to survival. So this study looked at about 250,000 people in the United States who were receiving dialysis during that time frame. In the period of the study, they identified about 45,000 people who had all been tested and were all considered to be suitable candidates for a kidney transplant, were all placed on the waiting list. Half of those, about 23,000, actually went on to get a kidney transplant during the time frame of the study, while the other half was still waiting for a kidney. Turns out, and this really surprised the community of transplantation as well as nephrologists, it turns out that if one then looked at the risk of dying every year for someone that was still waiting on dialysis for a kidney compared to someone that got a kidney transplant, the risk was about 70% higher, 1.7-fold higher every year waiting on dialysis. Now, since then, we've actually accumulated a lot of data in this regard, and I like to use this example. If you took a 20-year-old today who was in perfect health, with the average life expectancy in the United States being somewhere around 80, 85 years, that 20-year-old might expect to live another 60 years. If that 20-year-old for the first time suddenly developed kidney failure and needed to get onto dialysis, she or he might expect to live an average of about 20 years. Now remember, these are average statistics, so you take tens of thousands of people, some do better, some do worse. It's very difficult to predict for any given individual, but on average, that's what you might look at. If that 20-year-old was healthy enough and able to go through a successful kidney transplant, that individual might on average expect to live about twice as long compared to dialysis, so about 40 years on average. Again, some better, some worse, but about 40 years on average compared to simply staying on dialysis. Now, you might ask the question, why, if one kidney functions at a level that is adequate to maintain your health at a normal level, when you have a successful kidney transplant, why then don't you live the full 60 years? And that speaks to the limitations of kidney transplant. So even with careful selection, even with all of our testing in that early period in the first year, the mortality rate, the risk of dying in the first year is somewhere around 5.5–6%. If that doesn't sound very high, compare it to open heart cardiac bypass surgery, where the risk of dying in the period after surgery is only about 2%. So you're looking at almost a threefold increase in the risk. The risk comes not so much from the surgical procedure itself, but from the very, very powerful medications that we have to give you, especially in that early period, to prevent rejection. They have a lot of effects on your blood pressure, on your heart, and they also have, of course, the way they work is by lowering your immune system, so now you can't fight off infection. And so if you look at some of the typical events that may cause loss of life in the early period, heart attacks, strokes, and overwhelming infections are some of the common complications that we see. The other limitation of a kidney transplant is, even with all of the testing and selection, in the first year about 10% of people will lose the kidney. Some to rejection, but oftentimes to other complications, perhaps mechanical, or the kidney gets damaged in the course of trying to recover from an overwhelming infection, for example. And so these form limitations in terms of the early success. And then in terms of the long-term success, once you have a kidney that takes, even if it's working well, you have to take the rejection medication for the rest of your life. If you stop taking it, whether you stop it 5 years later or 10 years later, you will lose the kidney, unfortunately. But then the penalty of taking the rejection medicines is, yes, it's keeping your kidney going, but then it increases your lifetime risk of certain types of infections. It increases your lifetime risk of certain types of cancer. And so again, that forms another limitation in terms of the overall success of a kidney transplant. People will often say to me, you know, I'm doing so well on dialysis, I'm going to wait until I don't feel so well and maybe then I'll come for a kidney transplant. I'm not sure I want to take the risk upon myself right now. And that's the very worst thing you can do, because in fact, as it turns out, the best time to get a kidney transplant under ideal circumstances is when your kidney function is low enough, maybe down to about 15% or so, but not so low that you actually need dialysis. Of course, because the waiting lists are so long, very few of us are actually able to get a kidney transplant in a timely fashion. Most of us go onto the waiting list and have to wait several years. If you had a living donor, that might be one opportunity to perhaps get a kidney transplant before you actually get on to dialysis. And it turns out, and this paper was published in 2000, but it turns out that every 6 months that you're on dialysis has a very small but measurable negative impact on how you do even after you get a kidney transplant. I was talking about the waiting list increasing. I've been keeping track of this myself. 2004 summer, there were about 58,000 people in the United States waiting for a kidney transplant. Despite the fact that we're doing somewhere around 20,000 transplants every year, that number is up to about 95,000 now as of June of this year. Waiting times are quite long. If you look across the nation, the longest waiting times are for blood type B, closely followed by blood type O, around 5.5 to 6 years for the two blood types. Type A is kind of in between, it's about 4.5 years. If you're fortunate enough to have the so-called universal recipient blood type AB, then your waiting period is somewhere around 2.5 years. There's a lot of things that centers can do to actually help reduce the waiting time you spend on the wait list. I'm not going to go into details. You have these in your handouts. But it's important for you to know that here at Beaumont, compared to our neighbors in Southeast Michigan, despite having a single organ procurement agency for the entire state, by participating in all of those techniques and more, we're able to actually offer you a waiting time that is on average almost 2.5 years shorter than our neighbors. Now, it's all very well to say we get you to a kidney transplant faster, but you also want to make sure that you actually get there safely and you have a successful outcome. In 2015, for the first time, we were the federal entity called the SRTR that releases report cards on a regular basis, twice a year actually, to all transplant units, allowed us to compare our outcomes nationally. And at least in the year of 2015, we had the best one-year patient survival after kidney transplant in the country. I can tell you over the last decade and a half, almost 2 decades, Beaumont is the only kidney transplant center in Southeast Michigan that has never had a worse than expected outcome for one-year graft survival for kidney survival. For those of us that are looking towards kidney transplant, though, you have to go through an evaluation process, and the purpose of that is to assess for you as an individual what's safer. Remember, I said, despite all of our advances, kidney transplant remains still today a high-risk procedure, and so we have to be careful in selecting the appropriate person to go through kidney transplant so you're likely to have a successful outcome. At the very least, though, what I would say a successful transplant entails is to at least improve your quality of life, but ideally offer you that opportunity for a longer life as well. Obviously, it has to be someone that is already on dialysis or approaching dialysis. To get onto the waiting list, your kidney function needs to be 20% or lower. Ideally, though, we encourage people to at least start learning about it if their kidney function is down to 25% or less. You have to have adequate general health, not just to go through the surgery, but like I said, to be able to actually tolerate the side effects from the anti-rejection medications, which are probably the biggest part of kidney transplant in terms of the risk involved. And then you have to have not just the willingness, but you have to have the ability to participate in what ends up being a very complicated program. Those of us that are on dialysis are typically on a cocktail of medications that maybe are 12, 15 tablets through the day. Blood pressure pills, something for your diabetes, something for cholesterol, vitamins, phosphate binders, perhaps those hormone injections that I was talking about, the EPO or Procrit. Take that number and multiply it by about 3 times, and that's the number of pills that you'll be taking every day in the early period after a kidney transplant. Now, that doesn't last forever. After about 3 or 4 months, a lot of those tablets fall off. But in that early period, you'll be taking those tablets at very, very specific set times, 4 or 5 times a day. You've got to take them very precisely. You come in the morning to clinic, and we'll go over your medications, we'll look at your blood work, we'll make some changes. You go home, you faithfully make the changes in your pill box, rearrange everything. 6 o'clock at night, before our nurses are leaving for the day, they call you and say, "Hey, Joe, remember we made those 2 changes, here's 2 more. You've got to make it tonight because your blood levels are off and you've got to do the change immediately." Now, you may be in pain, you might be confused as a side effect of some of the rejection medications. You're tired, you might be trying to catch up with your rest and your sleep after having had a long day in clinic. Perhaps you didn't listen to your voicemail and you missed that call. You need someone who's looking over your shoulder and tapping you and saying, "Joe, did you listen to your messages? Did you remember to check if you need to make a change?" Now, the other part of it is in the first month, you cannot drive. You must not drive. The healing process is slowed down by the rejection medicines. And because you have the new connections between the blood vessels and between the kidney and the bladder, if you disrupt that by sudden forceful movements, you can get into a whole lot of trouble. You could even potentially die as a result of disruption of the blood vessels. So you still have to come into clinic 2-3 times a week. You may have to come in more frequently than that. Perhaps you come in on Monday, we do your blood work, we call you Monday night, your creatinine's off a little bit, come back tomorrow, we'll check it. So you come back the next day, creatinine's off a little bit more, come back on Wednesday, we'll do an ultrasound, we'll do a biopsy. So you come in Wednesday, we do the biopsy. Wednesday night, the pathologist calls me, says, "Dr. Summer, there's a little bit of rejection there. No big deal, about 20% of our patients will have mild rejection perhaps in the first year. So long as we diagnose it in a timely fashion, treat it right away, 95, 98% of the time we're able to control it, but timing is of essence. And so now you've got to come in every day, Thursday, Friday, Saturday, to get an IV treatment. And now suddenly, every single day of the week, you've had to have someone driving you in and driving you back home. So you've got to have all of those plans in place. You've got to have your support structure in place. Obviously, before you even get onto the waiting list, though, you've got to come into a transplant center, either ours or one of the many other fine centers that are here in our neighborhood. You come in and meet with the entire team, and it's a big team that you meet with. For those, some of you have probably already been through this part of the process. If there are some that haven't, you'd meet a nephrologist like myself, a medical specialist. You'd meet one of my surgical colleagues, our transplant nurse coordinator, our dietitian, our social worker, our financial coordinator. And then depending on your testing and your other needs, you might end up having to meet perhaps a transplant urologist, a transplant cardiologist, or perhaps even other specialists. You go through all of the testing. If all of the testing comes back okay, you get onto the waiting list. If your testing is not quite right, you might need additional intervention. So perhaps you had a heart stress test and the stress test was abnormal. You now have to have a heart catheterization to open up blockages, or perhaps even need a bypass surgery to get you ready so that it's safe for you to go through the transplant. If at that point, once you've gone through all of this and you get onto the waiting list, if you have a living donor that's been worked up and is ready to go, that's the point when we would schedule a living donor kidney surgery. But we look at a whole host of things. People will again ask, what is our age cutoff? When I came to Beaumont 2001, our upper limit was 65. Very shortly right after I joined, we increased it to 70. As we talked as a team, we felt that it was perhaps a little too stringent, and it turns out that literally 6 months after we had raised the age limit to 70, we actually transplanted a 72-year-old gentleman who had previously had a heart transplant, was losing his kidneys, got a living kidney donor transplant from his daughter. We said, okay, let's raise the age limit to 75. And so a couple of years after I came here, we raised it to 75. That lasted for about a hot second. We've transplanted folks in their late 70s, early 80s. Our oldest, we have now 3 people who were 82 at the time of transplant. I think the world record is an 84-year-old somewhere. We haven't quite got to that yet. But it is true that if you're older, you're likely to have additional medical problems, and perhaps not to have the strength and stamina that you need to be able to successfully go through a kidney transplant. So if you're older, it does make it harder. But I have been in the unfortunate position of having to turn down a 23-year-old because he was actually too weak to be able to successfully go through a kidney transplant. Broke our heart having to do that, but we did. And so age in of itself, I think, is a number, and so we look at a whole lot of other factors. I talked about the functional capacity, how much stamina and reserve do you have? That is a critical bit, especially if you're older. And so we do assess that very carefully. If you're overweight, some of us might be so overweight that the surgeons may say, you know, technically we just can't do this. You have to lose X number of pounds, come back and see us, we'll reassess, see if you've lost enough weight. But I have to emphasize that if you're overweight, even if our surgeons say, yes, we can do the surgery from a technical perspective, you want to do everything in your power to lose as much weight as you can as you're waiting for that kidney transplant. Skin and muscle tissue heals well, but the tissue in between, not so much. Remember, the kidney goes in the pelvis, and that's right where you have the fold of the belly as well, so it doesn't get to breathe much. And if you're overweight, it stays moist, it gets infected, but also the wound can very quickly rupture if you're carrying a lot of weight. And so as much as 70–80% of our patients that are particularly overweight will have wound complications. Now, if it gets infected, being on the anti-rejection medication, the infection can now become overwhelming and life-threatening. And if that happens, now you're really caught between a rock and a hard place, because we're having to back off on your rejection medication so that we can save your life from the infection, but then that sets you up at risk for developing rejection in the kidney and losing the kidney. So not many things that we can actually do to shift the needle from risk towards less risk. We can't make ourselves younger if we have diabetes, if we have heart disease. We can't take that away, but you can make yourself stronger and you can lose weight. And I know it's easy for me to stand on this side of the table and talk to you about it. I know how hard it is when you are unwell and suffering from kidney failure and on dialysis, but you want to do whatever you can to try and make that as safe as possible. And so every single day, even if it's 5-10 minutes a day, do something active that is focused exercise. Do it every single day, and every 2-3 weeks go up on the amount that you're doing. It'll be very, very frustrating when you first start. It'll feel like you're pushing against a wall, but suddenly in 3 months, in 6 months, you will notice there's suddenly been a big change, and I can't emphasize how important that is. Now we look at other things. Obviously, if you've had cancer, we want to make sure that the cancer has been treated adequately. Have we waited long enough that there isn't a risk that the cancer will come back? If the cancer comes back under the influence of the anti-rejection medicines, your body's immune system can't fight it off, and so that's something that is really important to look at. We also look at what is your risk of the original kidney disease coming back in the new kidney. I talked about that with the very first kidney transplant. Fortunately, it turns out that less than 5% of individuals will lose their new kidney to the original disease. There are a few rare conditions or uncommon conditions that are more likely to come back in the new kidney. If you have one of these, obviously we will advise you of that and tell you what your risk might be. I talked about some of the limitations of kidney transplantation, both in the short term and in the long term. There is also, even though we screen our organ donors very, very carefully, every once in a while there is a risk, even with the best modern testing that we have available, that perhaps we might inadvertently pass along either an infection or a cancer even with the organ. I was talking about the early risk. This is just another depiction of that. And really, if you think about it, because of that early risk of complications from a kidney transplant, if you look at the two groups of people that I previously talked about in that study, one group that's been tested, that's on the waiting list on dialysis, and the other that get a kidney transplant, in the first 3 months, survival is lower for those that get a kidney transplant because of that early risk. The risk becomes equal somewhere towards the end of the first year. And for those of us that get through the kidney transplant without major complications, with a kidney that's working well at the end of the first year, that 90% success rate today, those are the people that see the significant long-term benefit with not just quality of life, but actual improvement in survival compared to dialysis. In a very real sense, think about it as a gamble. You take that early risk for that significant long-term benefit. So once you get onto the waiting list, you go through a process of organ matching. And once you get called for a kidney transplant, oftentimes it happens in the middle of the night. Over the last several years, I'd say over the last 12 or 13 years, I've had 2 occasions where I make that middle of the night phone call. And typically when we make the call and say, Mr. Smith, we've got a kidney for you. It looks like it's a match. It's a good kidney. After that initial excitement wears off, one of the first questions that comes to me is, Dr. Summer, what kind of a kidney match is it? Is it a good match or is it not a good match? And of course, when we do the match for a kidney, we look at 6 levels of tissue match, not all of them. The 6 levels are important for kidney. And it may be a 0 out of 6 match, or it may be a 5 out of 6 match. Like I said, there were 2 occasions when I made this middle of the night phone call, and I can't remember now exactly what the match was, but it was obviously not very good. One of them was probably a 0 out of 6 match. One was perhaps a 1 out of 6 match. And on both occasions, the individual at the other end of the line actually, after a pause, said, you know, Dr. Summer, I'm going to wait until I get a better match kidney. And so that's when I started showing this slide, because it's very hard in the middle of the night to explain why that may not be such a good idea. Now, intuitively, we recognize that the closer the tissue match, the lower the likelihood of rejection, and so the lower the likelihood of losing the kidney. This is data from 2001. The blue lines are the number of kidneys that are still functioning at the end of the first year based on the level of the match, a so-called perfect match or a 6 out of 6 match compared to a 0 out of 6 match. And you can see indeed that there is a drop-off by the end of the first year, 91% of kidneys with a perfect match still working at the end of the first year with a perfect match, as opposed to 85% still working with a 0 out of 6 match. And then that number drops for all ranges, but 68% for a 6 out of 6 at 5 years, 55% for a 0 out of 6 at 5 years. Moving forward to newer data, this is already older data, but it's from 2010, 10 years on, but almost a decade old already. Look at the 1-year survival between a 6 out of 6 match and a 0 out of 6 match, 94% compared to 93%. Our newer medications to prevent rejection have virtually leveled the playing field. By 5 years, you can still tell a bit of a difference, 78% versus 70%. But again, that's only between the perfect match as opposed to a 0 out of 6 match. Most of us can wait a lifetime and never see a perfect match kidney. That happens maybe 2-3% of the time, and it's unpredictable. It may happen tomorrow night. It may not happen for another 20 years. For the vast majority of us, we'll get a level of match that is somewhere between 1 and 5 out of 6. And so those are the odds that we are faced with, and given our improved outcomes with the newer medications, what I urge my patients to focus on really is the quality of the kidney itself, because if it's a good quality kidney, even if it's a 0 out of 6 match, you're going to do better getting that kidney today as opposed to saying, no, I'm going to wait only for a 3 out of 6 match, and perhaps you wait another 2 years. That's 2 additional years of dialysis with a negative impact on your health. And then maybe 2 years down the road, when you get that 3 out of 6 match, it's an older donor, an older kidney, a not so good quality kidney. And so any benefit that you may have gotten out of a slightly better match is lost then because you didn't get such a good quality kidney. Pardon me. A patient said this to me once: finding out you need a transplant is a life-changing event, but even harder is finding the courage to talk to people you love about donating a kidney. It's another one of those questions that gets thrown to me on a regular basis. Dr. Summer, how do you talk to friends and family about donating a kidney? I can tell you my honest answer is I don't know. I've never been in your shoes. Our individual relationships are unique. My best advice to all of you is learn what it means to get a living donor kidney transplant. Have your family learn. And when they are better understanding of it, it may be easier for your family to talk to other people on your behalf rather than for you to ask for yourself. Why might you want to consider a living donor kidney transplant? There's the obvious issue of ideal timing. A lot of people look at it as, well, it's a matter of convenience. I don't have to wait for 5 years on dialysis. I can get a transplant right away. As I pointed out earlier, that's more than convenience. It really makes a huge difference in terms of your overall health and survival, how long you have to wait on dialysis. There is the possibility, perhaps, if it is someone who's a relative and is perhaps closely matched, that you won't need as much anti-rejection medication. But it turns out that regardless of the level of match and how closely related you are to your donor, if you get a living donor kidney transplant, you get significantly better outcomes. I talked about the 1-year risk of dying with a regular kidney transplant being somewhere around 5.5% to 6%. That's less than 2%, really less than 1% now with a living donor kidney transplant. If you look at the risk of losing the kidney in the first year, that's somewhere around 8 to 10% with a deceased donor kidney transplant. That figure is less than 4% in the first year with a living donor kidney transplant. So your early risk after a kidney transplant dramatically goes down, improving the likelihood that you'll see that long-term benefit. But then if you look at the longevity of the kidney itself and how that translates to better survival, that's quite staggering too. The average deceased donor kidney transplant lasts about 10.5, 11 years. Again, remember, these are average statistics. Some do better, some do worse. But on average, about 10.5, 11 years, whereas the average living donor kidney transplant lasts for as much as 18 to 20 years. Again, some better, some worse, but on average. And all of those translate then into very much better 10-year patient survival as well. Unfortunately, not everyone can donate a kidney, so you have to be healthy. You do not have to be genetically related. A full 35% now actually of our donors are non-related. Oftentimes a spouse or a significant other, but a lot of times we have friends, colleagues from work stepping forward. Over the course of my career, I've had 2 hairdressers that stepped forward and actually donated a kidney to long-term clients of theirs. You've probably heard of Facebook Friends. This is just one example here. This was a few years ago, 2014. The young lady there was a church member of the gentleman who needed a kidney transplant. Didn't really know him. She heard through somebody else that he was in need of a transplant, and she just stepped forward out of the goodness of her heart. Turns out she was a match. This is the 2 of them recovering the day after surgery. And then there's the question of what do you do if you have a perfectly healthy, good kidney donor, but they just don't match you because they're the wrong blood type, or perhaps you have what we call antibodies against their tissue type, and so you would reject the kidney if you got it directly from them. And so we participate in the National Kidney Paired Donation Program. Essentially, if you have a donor that doesn't match you but can be, could potentially be a healthy live donor, you go onto a registry, a wait list that's a national wait list, which is separate from the waiting list for a deceased donor. You could have another pair out in Utah perhaps where the donor again doesn't match their recipient, but that donor matches you, your donor matches that recipient, and we take the kidneys out, we fly them across, and with that swap now you have 2 individuals that benefit from a living kidney transplant, even though their own intended donor couldn't directly donate to them. This photograph just happened to be a 3-way kidney swap with local hospitals, University of Michigan, Henry Ford, and Beaumont, and they chose to meet after the event, and so this is a photograph taken at the time. People will ask if it matters whether you are a closer relative or perhaps not a relative at all. And in terms of living donor kidney transplant outcomes, you can see the blue and the yellow lines there for living related and unrelated transplants, virtually superimposed. You almost cannot tell the difference, and obviously both of them better than a deceased donor kidney transplant in terms of long-term outcomes. Who might donate a kidney? As I said, it has to be a healthy individual. It does have to be an adult. You have to be 18 or older. Again, our age limit for kidney donation used to be 60 years when I first joined here. We've had a few kidney donors in their early 70s. Again, as you get older, it may be harder for you to safely go through the surgery. As you get older, perhaps you may not have enough kidney reserve to be able to donate a kidney and remain safe yourself, and equally important, perhaps not enough kidney reserve to give to the other person as well. So we do look at all of those factors very, very carefully. We test our donors extremely carefully. We look at their medical history, we look at their family history to see, are there risk factors in the family medical history? How many people in the family have sugar, diabetes, high blood pressure? How likely is it perhaps that down the road you might get those? How might that impact your safety if you actually donate a kidney? We put our donors through a lot of testing. The surgery itself has come a long way. I kind of mentioned before, your own kidneys sit high up, and the typical approach, surgical approach, is a long incision that actually cuts through the lower part of the rib cage as well. Used to be extremely painful. Recovery would take 2, 3, 4 months. But really for the last decade and a half, our surgeons do the so-called minimally invasive laparoscopic surgery, pretty much 100%. They start with 3 small incisions, and at the end of the surgery, one of those is increased to about 4 inches to be able to take the kidney out safely. They don't put Band-Aids. This is for effect. They use surgical glue, and so you actually don't have anything on it, but it looks nice. For the carefully tested kidney donor who is healthy at the time of testing without any major risk factors, The data is very clear. By virtue of giving up a kidney, donating a kidney, and being left with one healthy kidney, if you look at future risks to developing general health problems, it's no different whether you have one kidney or two. If you look at future risk of developing kidney disease, it's no different whether you have one kidney or two. In fact, it turns out that if you look at longevity, if you look at survival, the very robust data, both from the US and from Western Europe, kidney donors very clearly outlive their counterparts in the general population. Not that I recommend kidney donation as a means to longevity, it doesn't work that way. But the fact is twofold, right? First, we tested you, you were healthy, and so we expect that you should outlive your counterparts. I think there is another effect as well. I think that most, unfortunately not all, but the vast majority of our kidney donors are more aware of their health after donating kidney, and that probably has a salutary effect as well. But the flip side is important. For a long time, as we allowed people to donate kidneys to save lives, we weren't sure as a medical community what the impact of reducing your kidney function from 100% reserve to 50% reserve would be. We speculated that it would be safe, but we didn't know for sure. And so it is very reassuring now with the long-term data that we have gathered that indeed it doesn't have an impact in your survival. You do not need to be on a special diet. You need to lead a healthy lifestyle, but not a special diet. You don't need to be on any special medications by virtue of donating a kidney. If you are a younger woman, if you're thinking that you might want to have children after donating a kidney, a couple of things to bear in mind. Most important, it doesn't have a significant impact on childbearing. It's safe, but you do want to wait a minimum of a year before you attempt to get pregnant. That's very important because with the one kidney that's left behind, you want to make sure that it has time to adjust and recalibrate, if you like. It compensates for the loss of the other kidney and kind of partially takes over the additional function, so you don't want to strain it too early. The other thing to bear in mind is there is a condition in pregnancy called preeclampsia. A lot of us have probably heard about it. It's a condition where you develop high blood pressure and certain changes in the kidney or the liver. And if not caught in time, it can progress to seizures and threaten the health and the life of the mother and the baby. It typically happens towards the end of the second trimester or in the third trimester. If you look at everyone who goes through pregnancy, on average about 2.5% of women will develop this condition. If you have donated a kidney or if you have just a single kidney for other reasons, your risk of preeclampsia goes up a little bit. It goes from 2.5% to 4.5%. Under these circumstances, it becomes very, very important that if you do become pregnant, you want to make sure that you are following with an obstetrician from a very early stage and make sure that they know that you have donated a kidney so they can monitor you, and if you fall in that 4.5% that develop preeclampsia, they detect it early, they treat it right away, and it turns out that so long as you do that, again, no impact in terms of health and survival to either the baby or the mother, but that follow-up is very, very important. And if you have donated a kidney, at the very least, we do recommend at least once a year for the rest of your life. Please make sure you go in, see a physician, make sure that they do a full physical examination, check your blood pressure, check your blood work, check your urine tests. Not because your risk of developing a problem goes up, but because your reserve is lower. And if you have a lower reserve, just by chance, if you were to develop a condition that could cause kidney damage, you want to make sure that you actually diagnose that as early as possible. And as soon as it's diagnosed, you want to make sure that you get it under control. And a typical example I like to use is high blood pressure. Hypertension is a silent condition. You don't feel ill from it. By the time you feel ill, it's too late, the damage is done. What if you're healthy today, you donate your kidney, but maybe 10 years from today you develop high blood pressure? You're not necessarily more likely to get high blood pressure because you donated a kidney. But when you get the high blood pressure, and if you don't know about it, and let's say it's poorly controlled for 4 or 5 years, then you go in to see your physician because you've got a cold or something and you accidentally diagnose the high blood pressure. Supposing in that time frame you've lost 30% of your kidney function. Well, if you started at 100% and you lost 30%, you're down to 70%. You now find out you have high blood pressure, you get it under control, you're safe for the rest of your life. But if you started at 50% and you've lost 30%, you're down at 20%. That's where we list you for a kidney transplant. And that's why we tell our donors it's critical. If you're letting us take the extraordinary step of plucking an organ out of you, the very least you need to do for yourself is make sure that you monitor yourself regularly for the rest of your life. I talked about this already, what happens if you have a healthy donor but they don't match. We can go through the paired donation program. For those of us that get onto the waiting list for a deceased donor kidney transplant, if you don't have a living donor, everyone who goes onto the waiting list goes on a standard waiting list. It's a standard list within the state. You're automatically on a national waiting list as well. These are for organs that come from what we would call now standard deceased donors. But several years ago, we developed a second waiting list for organs that came from individuals that passed away that were perhaps older, 60 years or older, or perhaps the individuals that the organs are coming from had certain health problems, like say high blood pressure or diabetes, and that might make the kidney less than ideal. We've been using these kidneys for a very long time because there's such a shortage of kidneys across the country. But then as a transplant community, we said, let's look at the data and see how do we best utilize these kidneys that are perhaps not perfect quality. How do we get the maximum advantage to our patients by utilizing these kidneys? And so we developed it's a computer formula that takes into account a multitude of donor factors, age, height, weight, and a whole host of other things. And it basically spits out what we call a kidney donor profile index. Physicians never make anything simple. It's always has to be a mouthful. We shorten it to KDPI. That makes even less sense. But think of it, it's expressed as a percentage. And just to give you a sense, if you have a kidney that's coming from a donor with a score, a profile index of 20%, what that means is if you compare the anticipated quality of the organ based on the computer equation, that kidney is likely to function longer than 80% of all kidneys that have been accepted for a kidney transplant. So we don't compare it to kidneys that were discarded because they were thought to be too poor. But if you look at all of the kidneys that were considered suitable for transplant and then compare them, a score of 20% means it's going to work better than about 80% or longer than about 80% of all kidneys that have been accepted. If you flip it around, and this is the list that I'm talking about, if you have a kidney that comes from a donor with a score of 85% or higher, that means that that kidney is likely to work for a shorter period of time than 85% of all kidneys accepted. And it turns out, indeed, I told you the average deceased donor kidney transplant lasts for somewhere around 10 and a half, 11 years. A kidney that comes from a donor with a score of 85% or higher typically lasts only about 7 or 8 years. So indeed, it lasts not quite as long. And so then the question is, who better benefits from getting a kidney like this, and what is the advantage of getting it? Now, one thing to bear in mind is, I said, everyone who goes onto the waiting list goes onto the standard waiting list. No one gets placed onto the waiting list for an organ from a score of 85% or higher unless you have expressly signed a written consent form ahead of time. If you don't sign the form, these kidneys will never even get offered out to you. The benefit of going onto the second waiting list is because there are fewer people who are accepting these kidneys, you're likely to get these kidneys faster, and typically about 2.5 years faster perhaps than waiting for a regular quality kidney. But then the question is, okay, you get it faster, but if it's not such a good quality kidney and it doesn't last as long, if I have a 20-year-old or a 30-year-old who's otherwise in good health, would I offer them this kidney? And the answer is no, I would not actually want that person to be getting these kidneys. Bearing in mind, who are the people that suffer the most from waiting a longer period of time for a kidney transplant? Intuitively, you would recognize this, but the data is also very clear about it. If you're older, if you have multiple medical problems and are a little more frail, you're less likely to tolerate waiting an additional year or two for a regular quality kidney. And so as we analyzed the national data, what we learned was the people who benefit from actually getting one of these kidneys are people who themselves are 60 years or older. If you have diabetes and you're 50 years or older, or if you're 50 and older on dialysis and you're likely to wait longer than 5 years, either due to blood type or some other reason. So these are the people that we actually recommend getting onto both waiting lists. And if you don't meet these criteria, then we recommend that you actually stay on just the regular waiting list and don't sign up for the KDPI at greater than 85%. I'm going to talk a little bit about the medications. This is an old cartoon. You've got a sports commentator sitting up there looking down. He says the surgeon looks to the left, pivots to the right, transplants the organ, and whoa, rejected. You've got a kidney splattered up on the ceiling over there. If you look at outcomes by decade, the green line here is one-year kidney success rates at the end of the first year in the decade before 1980, so in the 1970s. And you can see that the likelihood of the kidney working at the end of the first year was worse than a flip of a coin. Just barely 40% of kidneys were still working at the end of the first year. The blue line, the decade of the 1980s, when the first major breakthrough occurred in our ability to treat and prevent rejection. You've got the yellow line there for the 1990s, my chicken scratch over there in red. For the subsequent 10 years, every year, every decade, we've had improvement in outcomes. Why? 1954, the first successful transplant, identical twins who didn't have medication. Not until 10 years later did we first develop medications that could try and prevent rejection. One of those at least, well, both of those actually we still use, but especially prednisone, steroids. But as I said, 1980s, cyclosporin, a drug that was discovered in from a soil fungus in Norway. That's when we had the big breakthrough. And today we have almost a bewildering number of anti-rejection medications that we use either for the early prevention of rejection, the big guns at the time of transplant, or a combination of either 2 or 3 drugs that you need to use then for the rest of your life, what we call maintenance therapy. All of them have side effects. Some of them are what we consider first line, some of them are second or third line. But the big advantage we have with the choice now is in years gone by, if you had intolerable side effects from one of the medications, all we could do was stop it and stand by helplessly and hope that you didn't reject the kidney. At least today, it allows us a couple of different options. One, we can try and tailor the program to you as an individual, to your individual risks. Makes a big difference in terms of getting successful outcomes. But the other is if you do develop these side effects and we absolutely have to stop one of the so-called first-line medications, then we at least have backup medications to try and avoid the risk of rejection. Even with all of the advances, if you look at the list of some of the just common side effects from anti-rejection medications, it's a long, long list, and it's a frightening one when you read it. I talked about infections, certain types of cancer, skin cancer, very common, 800% higher in people who have got a kidney transplant. So you want to make sure once you've got your kidney transplant, sunscreen, sun protection, minimize direct exposure to sunlight, see a dermatologist at least once a year, make sure that you get yourself screened. The good news is melanoma, the really bad skin cancer, doesn't go up after transplant, but the what we call squamous cell and basal cell do go up. Those, though, if you go to see a dermatologist and it's detected in a timely fashion, it can be taken out without risk to your life. The other problem that people often deal with is the cost of the medications. So all of us know that Medicare covers the cost of the kidney transplant. Medicare covers the cost of the anti-rejection medications. But Medicare only covers the anti-rejection medications for 3 years. From the 4th year, if you don't already have Medicare by virtue of age, then you lose the coverage and you have to pay for those anti-rejection medications completely out of pocket. Even in the first 3 years, Medicare only pays for 80% of the cost of the medicines, and so 20% is still out of pocket. So you've got to make sure that you actually have a secondary prescription coverage in place. If you look at the average cost of a typical 3-drug program, over a year it costs about $15,000. If you were paying 20% of that out of pocket, that's $3,000 a year. That's a big chunk of change. So you really want to make sure you plan and you have these coverages in place. And that's not even looking at other medications. So it doesn't cover your blood pressure medications, your diabetes medications, any of those other medicines that you might need to maintain your health. And then there are the antibiotics and the antivirals that we have to give you for the first 3 to 6 months. One of them is a medication called Valcyte, valganciclovir. It helps to prevent a viral infection called CMV, cytomegalovirus. About 80–90% of us as adults have been exposed to this virus when we were young. When we first got the virus, we had maybe a fleeting illness. We shrugged it off. We were perfectly fine. But like a lot of viral infections, our immune system suppresses the virus but doesn't eradicate it, and so it kind of lies sleeping in our body. It's dormant. And under circumstances when our immune system is lower, either because of cancer, chemotherapy, HIV/AIDS, or a kidney transplant, the virus then activates. In the years when we didn't have effective treatment to prevent this virus, about 60–70% of our patients would get the disease. About half of them would lose the kidneys, and about a third of them would succumb to this infection. Today we have a drug that's virtually 100% effective at preventing it when you're taking it, and most of our patients need it for 3 to 6 months, but it costs $1,500 a month. Unless you're good friends with Bill Gates and he really, really likes you, you really need to have that secondary prescription coverage in place. So again, you've got to think about that. Ask our team to help you make that selection, but you've got to get the coverages in place. Ideally though, despite all of this, life after transplant, no dialysis, yay, hopefully return of your health to the way it was before you had the kidney failure. I talked about needing a ride, the frequent office visits, and the commitment. We do regular monitoring, blood levels, drug levels, looking for side effects, kidney function, but liver function, and many other tests, ultrasounds or biopsies. But hopefully we'll have the same kind of success that these two had. This made for a very catchy headline. Sue Lewis donated a kidney to her friend Sean Gotch. They were both triathletes before she donated. So if you're not doing that now, you won't do it after transplant. But the headline, as I said, was very catchy. After transplant, Michigan athletes' kidneys compete separately. Quite remarkable, actually. This was just, I believe, 6 months after they both recovered from surgery. Another remarkable surgery, the Nightingale sisters, Joanna and Lana. This was actually published a few years ago. To the best of my knowledge, they're actually still alive. This was it was published in 2011. Joanna, the young girl in the black and white photograph over here, was only 11 years of age back then in 1960. She needed a kidney, but the only match that they had for her was her sister, older by 1 year, Lana. But she was a minor, and minors may not donate a kidney. But they went through the court system, and they kept getting denied as they went through the system until they reached the Supreme Court of Massachusetts. Legend has it that the Chief Justice asked her, well, young lady, what are you going to do if I turn you down? And she apparently looked him in the eye and said, well, I'm just going to go to the Supreme Court of the land. And he apparently relented. I do not know the truth of that particular tale, but I think she convinced him that she had the understanding and the maturity to make that decision of her own volition. At any rate, they were obviously successful. That's the two sisters at the age of 63, 2011. The doll that you see in this photograph was actually donated by the President of the United States in 1960. They taught us a lot, these two young ladies, young at the time, perhaps not so young now. Both of them had successful pregnancies. We didn't know that you could donate a kidney and have a safe pregnancy. We didn't know certainly that you could receive a kidney transplant and have a successful pregnancy before then. If you look at future opportunities, a lot of intensive research, a lot of changes in our ability to treat and prevent rejection. Still far from ideal, of course, still rife with a lot of potential major side effects, but we're inching in the right direction. Ever so slowly, perhaps. The possibility of tolerance. What is tolerance? At the time of transplant, you take a foreign tissue, put it into your body, but somehow fool your body's immune system into thinking that that tissue is your own, So now you don't need to take rejection medication for the rest of your life. You don't have the side effects and complications of the rejection medication. A lot of intensive research has been done along these lines. Sadly, the body's immune system turns out to be far too smart to be able to fool in this way. And at least as of today, all of the techniques that have seemed initially promising haven't quite panned out enough for us to be able to adopt on a regular basis. Some form of gene manipulation perhaps, especially in combination with what we call xenografting. Xenografting is taking an organ from an animal and putting it into a human being. Some of us may remember 1984, a pediatric cardiac surgeon originally from South Africa, but was working here in the United States, transplanted baby Faye. She was 12 days old, was born with a heart that wouldn't function, and in those days the only option really was a certain death. Getting an infant heart small enough, literally the size of a walnut, to transplant was impossible, and he transplanted a baboon's heart. It worked for about 21 days, but with the differences in tissue type and the blood type, the severity of the rejection was such that the baby did succumb to it. For kidney transplantation, it turns out that a pig kidney is actually perhaps the closest in its functionality to a human kidney. And I was talking about genetic manipulation, so the tissue types are different enough that it's very hard to overcome the severity of rejection. But perhaps if we were able to somehow consistently introduce human tissue genes into the pig embryo, you could then grow a pig that has your tissue genes that you don't reject. And we could tailor-make an organ for you. A lot of work is going on with artificial organs, but I think with the kidney, the functionality is so sophisticated that that probably will not pan out. I think the future, I was talking about the pig kidneys, I think the future lies in some combination of bioengineering, even some type of 3D printing and tissue cloning. This is a now older paper, 2002. They used embryonic stem cells to fashion a rudimentary kidney, making urine of sorts. Fast forward a decade, and this is 2013, 6 years ago. They actually bioengineered using stem cells from a rat, a functioning kidney that looked like a kidney, had the structure and function of a regular kidney. They actually took kidneys out of the rat and transplanted this in its place, and it worked. Still very rudimentary, still working only at about 5 or 8%, not enough to make it viable for human transplant, but certainly proof of concept. I think that in the next decade or so, probably the first organ that will come to fruition in this fashion with a combination of cloning and bioengineering is going to be a human heart. And in fact, just recently, scientists from Israel and Tel Aviv University published their research having 3D printed a heart using human tissue with blood vessels and nerves, not functioning well enough for transplant, but again, I think anticipating in the next decade perhaps that might come to fruition. I think a kidney transplant, a functioning kidney is probably a little more intricate and is likely to take perhaps a little bit longer than that. But one of these days we might get our kidneys in a can